Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 389 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, JNN, an 18-year-old, 88-kilogram male college student, was diagnosed with epilepsy. He experiences generalized tonic-clonic seizures that last 2 minutes approximately 3 times monthly. JNN describes a churning feeling in his abdomen before his seizures. This is followed by involuntary right-sided jerking of his upper extremities. An EEG showed diffuse slowing with focal epileptiform discharges in the left temporal area. It was interpreted as abnormal. No correctable cause for his seizure disorder was identified despite a thorough workup. He has no other medical conditions and takes no routine medications. He was treated initially with carbamazepine up to 600 mg per day. He could not tolerate the medication because of nausea and diplopia despite relatively low doses. JNN's physician has elected to implement a therapeutic trial of phenytoin. I would like you to recommend an initial dosage. What information should be provided to JNN about his new medication? Selecting a non-toxic, therapeutic dose of any anti-epileptic drug is difficult without having information about the drug's disposition in the individual patient, i.e., prior dosages and clinical response. Although average dosages and resulting serum concentrations for phenytoin often are quoted, interpatient variability is significant. An initial phenytoin dosage of 400 mg per day, approximately 4.5 mg per kilogram per day, would be appropriate for JNN. In most patients, phenytoin therapy is initiated at or near the anticipated maintenance dose, e.g., 300 or 400 mg daily in JNN. If tolerability problems arise, JNN's phenytoin dose could be reduced to 200 mg daily, or 100 mg every 12 hours, and increased by 100 mg per day at weekly intervals until 400 mg per day is reached. Recently, there has been significant interest in using patient-specific genetic information to more accurately dose certain drugs, including phenytoin, with the goals of achieving a therapeutic effect quickly and avoiding dose-related toxicity. Although certain CYP2C9 homozygous allele variants have been shown to confer slow metabolizer status on patients treated with phenytoin, CYP2C9 genotyping of patients is not presently a part of routine clinical practice. Regarding patient education, in addition to the name and strength of the medication and instructions for when and how it should be taken, JNN should be informed that he may experience initial mild sedation from phenytoin. He should be cautioned that symptoms such as blurred or double vision, dysarthria, dizziness, or staggering may indicate that his dosage is too high. He should be instructed to notify his physician, pharmacist, or other healthcare professional of these symptoms. It is also a good idea to inform patients, at the beginning of therapy, that adjustments of medication dosage may be necessary before the regimen is stabilized. While JNN is at relatively low risk for osteomalacia given his age and gender, he should be informed that long-term use of phenytoin is associated with an increased risk of bone mineral loss and that this adverse effect warrants monitoring periodically. My next question to you reads: what are the characteristics of phenytoin accumulation pharmacokinetics? Phenytoin exhibits dose-dependent, i.e. Michaelis-Menten or capacity-limited, pharmacokinetics. Therefore, the usual pharmacokinetic concepts of clearance and half-life are meaningless. The apparent half-life of phenytoin changes with the dose and serum concentration. Thus, the time required to reach a new steady state after dose alteration is difficult to predict because it depends on the dose itself and the patient's pharmacokinetic parameters, Vmax and Km. Vmax is a kinetic constant representing the maximal rate of phenytoin elimination from the body. Km is the Michaelis constant, the serum concentration at which the rate of elimination is 50% of Vmax. Values for these parameters vary widely among patients. As a result, patterns of phenytoin accumulation and the time required to achieve steady state also vary. Many clinicians assume that phenytoin's apparent half-life is approximately 24 hours, and they wait 5 to 7 days before assessing the patient's clinical response and measuring serum phenytoin concentrations. Both clinical studies and model simulations using observed values for kilometer and Vmax have been used to estimate time required for serum concentrations of phenytoin to reach steady state. Up to 30 days may be needed for this to occur, either with doses sufficient to produce steady-state serum concentrations of 10 to 15 micrograms per milliliter or with doses of 4 milligrams per kilogram per day. Occasionally, such a dose may exceed a patient's Vmax. The result is extremely high serum phenytoin concentrations, with probable intoxication. It is important not to assume that steady state has been reached unless widely spaced. Serial serum concentrations indicate that accumulation has ceased. Alterations in phenytoin dosage before steady state has been reached can result in significant fluctuations in serum concentrations and the patient's clinical status. Such situations occur frequently and result in unnecessary confusion and expense. As always, serum concentrations in JNN must be interpreted in the context of his clinical response. JNN was started on phenytoin and is now taking 200 mg every 12 hours. 1 week after achieving this dose, mild lateral gaze nystagmus was noted, but JNN had no subjective complaints and was seizure-free. After 3 weeks, JNN complained of double vision and feeling drunk and unsteady. Significant nystagmus was present. So my question to you reads: how should JNN's phenytoin dosage be altered? JNN's signs and symptoms indicate phenytoin intoxication. Dosage reduction is indicated. Reducing JNN's dosage to 360 mg per day, accomplished using both 100 mg and 30 mg phenytoin capsules, would be reasonable. A larger reduction may result in a loss of seizure control. Many clinicians also would have JNN omit 1 day's dose of phenytoin before beginning the new maintenance dosage. This would accelerate the decline in phenytoin serum levels. After this dosage change, clinical response should be monitored closely. The new maintenance dose may still be excessive if JNN's Vmax for phenytoin is low. If this were the case, continued accumulation of drug would occur despite the dosage reduction. The next clinical case reads, SDD is a 24-year-old male institutionalized patient with a history of complex partial and secondarily generalized tonic-clonic seizures. Within the past year, his phenytoin formulation was switched from phenytoin sodium capsules to phenytoin suspension because SDD was suspected of cheeking his medicines and not swallowing the capsules. He has had no seizures in the past 3 months on 275 mg per day of phenytoin suspension. SDD has now been transferred to the acute medical unit after a 2-day history of anorexia, nausea, occasional vomiting, and abdominal pain accompanied by diarrhea. His chart now states, nothing by mouth. Phosphonytoin, 275 mg, phenytoin sodium equivalents, abbreviated as PEs per day, has been ordered. I would like you to discuss the use of phosphonytoin, and devise a dosage regimen for SDD. SDD is a candidate for parenteral administration of his antiepileptic drug. If placement of an IV line for fluid administration is not planned, then IM administration is an acceptable approach to treatment. However, the type of phenytoin product administered will need to be changed. Phenytoin, itself, should not be administered by IM injection. Injectable phenytoin is highly alkaline, that is a pH of 12, and extremely irritating to tissue. After IM injection, the drug may precipitate at the injection site because of the change in pH. As a result, phenytoin crystals form a repository or depot from which the drug is slowly absorbed. Often injection site discomfort is noted, although severe muscle damage does not seem to occur. Fosphenytoin, a phosphate ester prodrug of phenytoin, is highly water-soluble. Its solubility allows this preparation to be administered parenterally without the need for solubilization using propylene glycol or the adjustment of pH to non-physiologic levels. Therefore, fosphenytoin may be administered either IM or IV with less risk of tissue damage and venous irritation than with parenteral administration of phenytoin. After administration, fosphenytoin is rapidly absorbed and converted to phenytoin by phosphates enzymes. Ultimately, the bioavailability of phenytoin from fosphenytoin administration is 100%. Fosphenytoin is available as a solution containing 50 mg phenytoin sodium equivalents per milliliter. By labeling fosphenytoin this way, no dosing adjustments are necessary when converting from phenytoin sodium to fosphenytoin or vice versa. Although the prescriber ordered 275 mg phenytoin sodium equivalents, SDD may be underdosed. His oral dosage of phenytoin suspension is providing the equivalent of 300 mg per day of sodium phenytoin. Phenytoin suspension and chewable tablets contain free acid, whereas capsules contain sodium phenytoin. Therefore, phenytoin capsule products contain only 92% of the labeled content as phenytoin acid, i.e., a 100 mg sodium phenytoin capsule contains only 92 mg of phenytoin acid. He should receive a 300 mg dose of fosphenytoin daily to fully replace his current dosage of phenytoin suspension. Assuming that SDD will be given 300 mg phenytoin sodium equivalents of fosphenytoin daily, he will require a total of 6 ml of this injection given IM. This medication is well tolerated when given IM, and SDD's full daily dose can be given in a single injection without causing excessive discomfort. Some clinicians report administering IM injections of fosphenytoin as large as 20 ml in a single site without adverse consequences or serious discomfort. It is also possible to divide his daily dosage into 2 injections given in 2 different sites, although many patients prefer to receive fewer injections. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 390.